Good evening, everyone, and thank you for joining us for the August webinar with the Scleral Lens Education Society. Tonight's webinar is going to be on higher order aberrations with novel scleral contact lens technologies. So we have two great speakers with us tonight. First, we have Dr. Barry Iden joining us from the Chicago area. He is the president and medical director of the North Suburban Vision Consultants, which is a multi-specialty group practice in the Chicago area. He is president and co-founder of the International Keratoconus Academy of Eye Care Professionals and the IVIS Eye and Vision Research Institute. Dr. Iden is an assistant clinical professor at the University of Illinois at Chicago Medical Center in the Department of Ophthalmology, and he is an adjunct faculty member at Indiana, Illinois, Midwestern, Salus, SUNY, and UMSL College of Optometry. So I think we might have covered all of them there. Dr. Iden is on the editorial board of numerous professional journals and frequently publishes in various professional literatures. He is also the past chair in the the past chair of the American Optometric Association's Contact Lens and Cornea section. He is also a fellow of the American Academy of Optometry and a fellow of the Scleral Lens Education Society. Dr. Iden is a research consultant for numerous contact lens, technology, and pharmaceutical companies, and he lectures extensively both nationally and internationally. Thank you so much for joining us.
My pleasure, Roxana.
We also have Dr. John Gellies, who is the director of the Specialty Contact Lens Division of the Cornea and Laser Eye Institute and the CLEI Center for Keratoconus in New Jersey. He is a clinical assistant professor at Rutgers, New Jersey Medical School in the Department of Ophthalmology and Visual Science. And he is also adjunct clinical professor at SUNY, NECO, and Illinois Colleges of Optometry. Dr. Gellies is a fellow of the Contact Lens Society of America, the Scleral Lens Education Society, the British Contact Lens Association, the International Academy of Orthokeratology and Myopia Control, and a PROS clinical fellow. Dr. Gellies is a board member of the Contact Lens Society of America, an executive board member of the International Keratoconus Academy, and an advisory board member of the GPLI. His clinical work is dedicated exclusively to specialty contact lenses and the management of keratoconus and other corneal diseases, ocular surface disease, and post-surgical corneal conditions. Additionally, Dr. Gellies is an investigator for multiple keratoconus and specialty contact lens related clinical trials, and he is a consultant for numerous related technologies and companies. Thank you, Dr. Gellies, for joining us.
Okay, say thank you, John.
Sorry, I'm muted. Thank you. That's how we're going to start the webinar tonight, I guess.
That's exactly it. Great. Roxana, should we take over from here?
Yeah, you guys are good to take over. Excited to hear, all y'all's knowledge on this topic.
Fantastic. Thank you. And thank you, everybody who's tuned in from the Scleral Lens Education Society. John and I are really thrilled to share some of our experiences in working in aberrometry and with some of the new novel contact lens designs that address residual high order aberrations. So thank you to all of you. And John, you have any hello words for everybody?
Yeah, just hello, everybody. Thank you for joining. And Barry, take it away.
Take it away. Okay. So this is kind of an overview of what we're going to talk about this evening. We'll basically talk about visual aberrations, ocular aberrations specifically. We'll talk about some of the technologies involved in diagnostics and measurement of aberrometry, how it relates to various ocular diseases. We'll then talk about the influence of contact lenses on aberrations, both positive and negative. And then we'll end the talk talking about some of the novel contact lens designs that John and I have used to address high order aberrations in contact lenses. So I'm going to start off, and then John is going to kind of take over the second portion of the talk tonight. But if we have questions or comments, feel free to put them in the chat section. I guess Roxana may be monitoring that and let us know if anything needs to be brought up during the talk, or of course we'll be around after the talk as well. So let's begin. Let's talk about what are aberrations. And I'm going to try to make this as clinical and as simple as can be, because that's how I like things presented to me. So we can talk about visual aberrations in terms of two basic categories: low order aberrations and high order aberrations. Now, low order aberrations, predominantly as it relates to us clinically, we're talking about the spherical component, meaning myopia or hyperopia, and astigmatic error. So these are what are called low order aberrations. Yes, there's something called prism and tilt, first order aberrations, where the sphere and cylinder are second order aberrations. But truly, as it relates to us clinically, it's the spherical component and the astigmatic component that we're all very, very familiar with in dealing on a day-to-day basis. Then we have high order aberrations, and there are many of them and many orders of these high order aberrations. Probably the three most common that we deal with are coma, trefoil, and spherical aberration, but there are many, many others. Now, let's talk about that a little bit. We know, again, in terms of low order aberrations, we deal with that on a daily basis. We measure them in the phoropter and other standard refractive technologies. But the high order aberrations we've learned about when we were all in school and learning about optics. But once we graduated and completed our boards, the truth is we kind of knew about them, but we really never addressed them until recently. And the reason is that we didn't have the technology until recently to actually measure these things in practice. But now there are numerous clinically applicable aberrometers that we can use on a daily basis in practice. Our practice has been involved in one way or another with aberrometry for over 15 years. We've had probably about 6 different systems in our practice at one point or another. And we'll talk about the different kinds of technologies and what differentiates one from the other as we move forward. But just to let you know, at our practice, we utilize one of our aberrometers as, in essence, a screening device, because this instrument is multifunctional. It serves as an autorefractor, an autokeratometer, and an aberrometer. So all of our patients that would normally get autorefraction, we use this instrument. And we can see the aberrometry values and the aberrometry outcomes for every one of these patients in the exam room. And it becomes amazingly valid and amazingly impactful in terms of our analysis of what's going on with this patient's visual system immediately as soon as we look at the outcomes. And you'll see some of those examples in a moment. So how do we define high order aberrations? Simply, we can define them as any refractive error that cannot be corrected by spherocylindrical lens combinations. So all of the high order aberrations, there's nothing that we can really do with our traditional lens technologies, whether it be, ophthalmic lenses for spectacles or traditional contact lens technologies. When we're using sphere and cylinder to correct those low order aberrations, we're not addressing the high order aberrations. Now, high order aberrations, interestingly enough, depending upon studies that we read, will make up anywhere between 10 and 15% of total aberrations for normal eyes. Not for abnormal eyes, they become much greater, but for normal eyes, even those patients experience, the effect of high order aberrations affecting their visual function. So what I'm showing you here is an example, a breakdown of low and high order aberrations. And you could see the order of aberrations on the left. RMS we'll get into in terms of root mean square, but suffice to say, the low order aberrations and the high order aberrations in this particular individual who attained uncorrected 20/10 vision and had an autorefraction that was in essence nothing, you can see those bars representing the magnitude of those aberrations, low order and high order, both are extremely low. That's why this individual functions at an extremely high level visually. Now we'll take a person who simply has refractive error, but very low high order aberrations. And we can see this patient has predominantly a spherical error, that's called defocus, and some moderate astigmatism, but the high order aberrations remain quite low. So with a traditional correction, we would expect this individual to see very, very well and have really high quality visual performance. Compare that to a keratoconic. The keratoconic, as we all know, also has low order aberrations. We know we measure high degrees of astigmatism and often high degrees of spherical error, but you can see the high order aberrations are also dramatically elevated in this particular person who has keratoconus. So what are the sources of aberrations in the visual system? The ones on the top in the ocular component are really the ones that we're going to talk about clinically. Those include the tears, and believe me, they can have a significant impact on aberrations, high order aberrations. Secondly, the cornea. And let's start keeping in mind when we talk about cornea, we need to talk about the anterior and the posterior shape of the cornea, as well as what happens in the stroma in cases, for example, of scars that can induce high order aberrations as well. The aqueous has minimal effect, but then we get to the lens, especially as lens opacities and cataracts develop, they can dramatically influence high order aberrations. So you can have patients, and we do see this all the time, who are quite symptomatic from their cataracts, but they're correctable to decent levels of acuity, 20/20 minus, 20/25, but they're highly symptomatic. They have very high levels potentially of high order aberrations. Of course, things in the vitreous can influence that as well as the retina, but predominantly, clinically, what really comes into play is tear film, cornea and its individual elements, as well as the internal crystalline lens. So those are the important elements of our ocular system that impact high order aberrations. But in terms of other influence, even our corrective therapies can influence high order aberrations, both in a positive and negative way. Certain spectacles, certain contact lenses can actually increase our level of high order aberrations. And of course, as we'll talk about later, sometimes they can actually be used to decrease high order aberrations. Intraocular lenses, we see this all the time. Again, because we run aberrometry on, in essence, every patient that we do an exam on, those who have had IOLs, even with very good acuity, we often see residual high order aberrations. If the lens is decentered a little bit, some of the multifocal lenses, especially when those are decentered, so on and so forth. Of course, refractive surgery very often can cause influences in high order aberrations. Early forms of refractive surgery increased high order aberrations. Now, with topography-based and aberrometry-based LASIK and PRK, we're seeing that we can actually influence in a very good way to reduce some of the residual high order aberrations. And of course, trauma can influence the ocular system in ways to do so as well, whether it be corneal trauma or influences on pupil and pupil size or pupil shape, all can influence high order aberrations. Let's just get some basics down. What is an aberration-free eye? By the way, it doesn't exist, but if it did, all of the lights, all of the parallel bundle of light rays entering the eye from distance will be focused on the retina on a pinpoint level, be perfectly focused on the retina. So that when light exits the eye, and aberrometry theoretically is measured in this particular type of circumstance, the lights exiting will also be parallel, and this forms a totally flat wavefront map. Now, this again does not happen clinically. There is no totally aberration-free eye. But if it did, that aberration map would look like a single color, in essence, indicating a flat wavefront. And we know this doesn't exist. The variations from that wavefront will vary according to the degrees of aberration. So an imperfect wavefront is obviously any deviation from that flat plane. And these are called aberrations, whether they be low order or high order. And we can see here in an aberration map, an aberrometry map, you can see the color variation indicating non-planar forms of aberration maps. And we mentioned before, there are various levels from low order to high order. Many of these terms we've heard of trefoil, coma, spherical aberration, quadrifoil, secondary astigmatism, and such. And again, we can describe these mathematically, but suffice to say, some of them, like coma, like trefoil and spherical aberration, are some of the most common and most significant we encounter in clinical practice. So let's talk about some key terms. We've already talked about low order versus high order aberrations. Let's now move on to the term root mean square, or RMS. You're going to hear this value talked about a lot. Now, when we start talking about RMS, you can break it down into various subcategories: total RMS, or low order versus high order RMS, or total system RMS, meaning the entire visual system in terms of RMS, or breaking it down to corneal versus internal. And you'll see new technologies are enabling us to break that down even further. We'll also talk about the point spread function. And again, you could break those down into those subcategories, and we'll show you that in a bit. So what is root mean square, RMS? Basically, what it is that it takes all of the wavefront elevations and it squares them in a mathematical formula and then takes the root mean. What the heck does that mean? I don't know. I remember learning this years ago. It doesn't matter. The bottom line is that RMS is equivalent to a quantification of aberrations. So if we're talking about high order RMS values, it's taking all of those high order aberrations and quantifying them into a number. The higher the number, the more high order aberrations we have. Now, if you're looking at RMS, that specific number does not break it down into the individual components. So how do we think about a root mean square? That was pretty cute. I thought I came up with that thing there. So we got root, mean, and square. So what's the analogy for RMS? To me, the best analogy is a spherical equivalent for low order aberrations. A spherical equivalent combines the sphere and the cylinder value to give you kind of a quantification of overall refractive error for low order aberrations. The RMS does the same for all aberrations, but when we're talking about it, we're going to talk about high order RMS. So again, it's a quantification of the aberrations. So total RMS error allows us to calculate total aberrations versus breaking them down into low order versus high order. But you can further differentiate it to the total visual system, the cornea, and internal, and even subcategories of that. So when we're talking about it clinically, and John and I will be mentioning this, and we talk about RMS values, we're really referring to high order RMS, and sometimes we'll break that down to total versus front of cornea versus back of cornea versus internal lenticular high order RMSs. Now we'll talk about point spread function. To me, clinically, one of the best, most useful educational tools for our patients. Because what is a point spread function? It's a pictorial representation of what happens to a point source of light that's focused through an optical system. So once again, you can do a point spread function image or create one for total aberrations, including low order and high order. I don't find that tremendously useful, to be honest with you. So most of the time when I demonstrate it to the patients, if not exclusively, we're showing point spread functions for high order aberrations. And interestingly enough, those of you who do aberrometry in your practice know that this is true. But when you show these point spread functions to patients who have elevated higher aberrations, often they'll go, oh my God, that's exactly what I see when I look at a light at night. So you can see in the demonstration below that if there's minimal higher aberrations, the high order point spread function will look very close to a point of light. The middle one is showing vertical coma high order aberrations. And then the one on the right is a complex of a variety of high order aberrations influencing the image of the point spread function. So once again, we use this all the time in terms of education for our patients, but I also look at these results that come out on our aberrometry displays to give me a very quick look at what's happening. So if I see, for example, it's broken down into total, anterior corneal, and internal, if I see those all being close to a small point of light, I know that there are no high order aberrations existing. I don't have to look at the numeric RMS values. I can see what they are right off the bat pictorially. Let's talk about the concept of auto calibration. This is important, and it'll become even more evident later on as we speak. And that is that the whole is often greater than the sum of its parts, meaning that sometimes the high order aberrations of the cornea, of the lens themselves individually, are greater than the total high order aberrations. In essence, one offsets the other. And we see this quite often clinically, and that has a very, very significant impact on how we manage these patients with contact lenses. And we'll see that in just a little bit. So you can see an example here where the entire visual system or whole eye point spread function is much less than the cornea or the internal optics. It's an example of how that offset occurs. Now, what about pupil size? No surprise here. In a typical normal eye, aberrations become more apparent as the pupil size increases. This is even true for abnormal eyes. Larger pupil sizes, typically, you'll see high order aberrations increase. And in typical eyes, when the pupil size reaches about 6 millimeters, that's when high order aberrations really have some of their more debilitating impacts on vision. So as the patient has night experiences, we would expect that they're going to be more symptomatic. And we see that clinically, of course. And we can see here an example of a patient with a 2 millimeter pupil, a 3 millimeter pupil, a 5 millimeter pupil, and a 6 millimeter pupil. And you can see what happens as you enlarge that pupil size for the same patient to the point spread function, how it increases. The tear film, I just want to really emphasize the significant role that dry eye can play on aberrometry and high order aberrations. High order aberrations after tear film breakup have been shown to increase by about 1.5-fold compared to the high order aberrations before tear film breakup. Now, why is this important? As we're measuring aberrometry and you're seeing abnormalities, especially of the external or the anterior, it's influenced both by the tear film and the shape of the anterior cornea. And you have to make sure that you're not getting influences of the tear film confounding the way you're looking at the anterior cornea. How do you do that? You do repeated measurements. And often you'll see variability in those readings, especially with these integrated aberrometers we'll talk about that use placido maps. And we'll see the placido distortion changing from one measurement to the next. Or if you did a video, you would see it change over time. And we've seen many, many cases where we can measure improvements in high order aberration measurements when we manage a dry eye patient or ocular surface disease patient. And of course, age has an effect as well, primarily due to the internal crystalline lens as we start to develop cataracts. One of the most common things we see as cataracts develop are increases in trefoil. So that pattern that you can see in the map of trefoil is very, very common as internal cataracts develop. And here you can see a different case. You know, what I want you to notice, and we're going to do a couple of these cases. I don't know if you can do, I hope you can see my, my marker, but on the upper left, that's total high order aberrations. In the center is anterior high order aberrations, particularly the tear film and anterior cornea. And to the right is the internal. In this case, it's due to cataract. And look at the pattern of the aberrometry map. It looks almost the same for the internal as the total. And it's telling you the high order aberrations are truly being induced by the internal, in this case, early cataract development. Let's talk about technologies. So there are tons of aberrometers out there. Many of these in these photos we've actually utilized in our practice. And each of them have different types of functions and different advantages and disadvantages. So specifically, what I want to share with you is a concept of a traditional aberrometer versus what I've termed an integrated aberrometer. So what's a traditional aberrometer? Basically, it measures total aberrations. low order, high order, but it doesn't break it down into where the source of these aberrations are coming from. That happens when you have a system that is what we call an integrated aberrometer. These are multifunctional instruments. They often will combine aberrometry, placido topography, autorefraction, autokeratometry, and now even corneal tomography, as we'll see in a couple of moments. And that can differentiate, in essence, the source of these aberrations, which is extremely helpful in terms of management, in knowing what we can and can't do, or where we really need to put our efforts into addressing these high order aberrations. So in integrated aberrometry, of course, we can break it down into low and high order aberrations, but we could further break it down to external aberrations, the tear film and anterior cornea, as well as internal aberrations. Posterior cornea influences that, crystalline lens, and such. Again, we could break it down to low order and high order, but typically we're most concerned in aberrometry of high order. And we can see here an example of a patient who has, again, cataract, very low degree of external high order aberrations. Internal aberrations is pictorially represented in the point spread function, as you can see, and the total is very similar to the internal. So that's a cataract case. Now, corneal and anterior segment tomography can also be used because you can measure the anterior corneal shape, you can measure the posterior corneal shape, and when you can do and global pachymetry, but when you're doing that, you can also measure the aberrometry findings of both the anterior and posterior cornea. And so you're able to really do an amazing type of analysis for the first time. And the system that both John and I use is the new Pentacam AXL wave. It integrates aberrometry along with corneal tomography, as well as global pachymetry. And actually, this instrument also does biometry. It can measure axial length and does corneal scleral profiling. It's a pretty amazing multifunctional system. And both of us have been using it over the last year. And I think both of us are really starting to learn more and more and work with some of the software and helping improve that. And that's an example of the AXL wave from Oculus. And in that particular instrument, it can give you an overview of total visual performance, iris images, all kinds of things. And you can see the aberrometry findings in the upper section and the tomography findings in the lower section, and even the biometry in the center. So we can see all of that. And we can see here an early cataract where we can see the effect of the internal elevation of high order aberrations in the simulated E being very similar to the total aberrations, yet the cornea is actually quite clear. And here's an example of a post-RK patient. Look how bad the cornea looks. The internal is obviously actually offsetting a little of that because the total looks a little bit better than that corneal image, right? And again, in that regard. So this is really something very, very new. And now we're going to help work with them in developing some of their software, to be honest with you. I was on a call earlier today with them, talking about the importance of ways in which we can demonstrate the effect of the anterior versus posterior cornea. Many of us are coming upon many patients who have keratoconus, developing cataracts. We know their high order aberrations are increasing. And what does that due to? Is it due to the keratoconus? Is it due to the back of the cornea, the front of the cornea? Or is it due to the lens, or what combination? So that's the kind of information an instrument like that can give us. So let's just do a couple of examples of regular aberrometry, not applying contact lenses yet. Here's a perfect example of a classic keratoconus case. And we can see the total wavefront map showing classic keratoconic kind of appearance, the cornea, the anterior cornea on the upper right, and the internal on the lower left. So this is fairly classic. And if you look lower right, the Zernike breakdown of all of the high order aberrations are pointing to the fact in this case that coma is the real culprit, as you can see in that red bar. Let's use an example. Here's a patient of ours, a 63-year-old keratoconic male, keratoconus that was greater in the right eye, clinically relevant, and subclinical in the left eye. Let's just talk about the right eye in this example. There you can see the manifest refraction with high cylinder, 20/30 -3 acuity. The cornea showed vertical striae, Fleischer's ring, but no scarring. But he did have +1 NS and some anterior cortical changes at his age. We did a diagnostic scleral fit, and we had significant improvement, but we had hoped for even greater improvement based on the degree of corneal distortion. Here we can see his tomography. Nothing unusual as a keratoconic, fairly well-centered apex of the cone, moderately steep, mildly thin, not too excessive. But here we can see integrated aberrometry here using the NIDEC OPD system. And what we see is an elevation of high order aberrations that's contributed both by the keratoconic cornea, but there's also internal elevation of high order aberrations. And we can see that breakdown, the total versus the corneal versus the internal. Those numbers in the center circle, in this instrument, anything over 0.25 is considered abnormal. You can see both the anterior corneal, the internal, and the total are all elevated in this case of keratoconus. Now we put a diagnostic scleral on. Take a look at that point spread function. I'm going to go back. There is without a lens. Here is with a lens. And what do we see? The front of the cornea, those high order aberrations are almost entirely eliminated. But there is some degree of residual posterior or internal elevation of high order aberrations that contribute to an increase in total high order aberrations. And that's induced both by the back surface of the cornea and by the lenticular changes in this particular individual. We could see here more clearly the point spread function. Without the lens on the top showing the internal, the anterior corneal and total, as well as the bottom when the diagnostic scleral is on. Anterior cornea is almost totally eliminated, but the total still has some moderate elevation in the high order aberrations. So what else can induce high order aberrations other than cataracts? Well, of course, a PCO, posterior capsular opacification, after cataract surgery is a real common one that we see. Yeah, less commonly, retinal elevations can theoretically do it. Vitreous hemorrhage can do it. Those are obviously much less common. But in keratoconus that we all manage together, it's that posterior cornea. We have, until recently, not given credit to the impact that the posterior cornea can have on visual function. We've always thought about that anterior because that's what we're able to mask with our rigid contact lenses or even some of the keratoconic soft lenses. But you could see posterior cornea can have a great effect. Now take a look here at the influence of internal high order aberrations in a relatively young individual who has a clear lens, but their internal high order aberrations are dramatically elevated. You can look at those point spread functions. Total on left, anterior corneal on right, and internal on left. This instrument cannot differentiate between the back of the cornea and the internal lens. But in this particular circumstance, the internal lens was actually optically clear. Here's, again, a 28-year-old male with a clear lens, recently diagnosed with keratoconus at our practice. And there we can see the other eye. And we can see here the right eye without correction showing high order. And these point spread functions are all high order aberration point spread functions, not total aberrations, including low order. And there's the left eye, similarly elevated anterior cornea internal, which is due to the posterior corneal shape, and total. Now we put a soft keratoconic lens on, and we've improved some of the numbers, but you can still see the high order aberrations are quite significant. And there's the left eye with a keratoconic soft lens that was fitting well, but we put a vaulting hybrid lens on the eye, and look what happened to the anterior corneal high order aberrations. Almost eliminated, dramatically reduced with significant improvement in vision, but still residual internal high order aberrations that come through. So if you look at the total on the left, look at that point spread function, and the total of the internal, they look almost identical. And the numbers are actually quite similar. This is the other eye. So residual total high order aberrations in keratoconus can be induced when a scleral lens is on the eye by posterior corneal irregularity. And we can see that here. Here we have a lens on the eye. Look at the residual internal. Look at the total. They're almost the same. And those are the things that John and I have been addressing, and John will address in specific ways in a few minutes with contact lenses. Here's an even more dramatic case. Look at this case with a scleral lens on the eye. Again, anterior corneal high order aberrations virtually eliminated. But look at the amount of internal high order aberrations. This patient will not function well with a traditional scleral without addressing these residual high order aberrations. Now, what about offset? Offset, I alluded to you before, when the external and internal high order aberrations kind of negate each other or minimize each other. So if we look at the numbers specifically, internal 0.44, corneal 0.53, but the total 0.247. If you put a rigid lens on this patient, whether it be a corneal rigid lens or a traditional scleral, what's going to happen? All of a sudden, that internal is going to pop through, and I will tell you, they will do worse in that lens than they will in glasses. So this is a case where a patient may end up actually doing fairly decently in glasses, or even a very draping type of soft traditional disposable lens. They may do better. And I have many patients with keratoconus that have this situation, and they come in and they're doing pretty well in their glasses. They're wearing standard contacts. And we look at the anterior corneal shape, whether you're doing placido topography or tomography, and you say, what? They've got keratoconus. How could they be doing so well? Well, there's offset. And you got to be really careful about this, because you think you're being a hero in putting this rigid lens on their eye, whether it be a hybrid, corneal rigid, or a scleral, and they end up doing worse. There's a tremendous example. Now we put that scleral lens or rigid lens on the eye. Look what we've done to the internal, nothing. What we've done to the anterior corneal, eliminated it. And look what residually happens. Patient's going to be miserable with this level of vertical coma. So now we're going to get into, oh, that must be me on some sort of audio. I will talk about that. Sorry about that, guys. I think I had recorded something, and I don't know how to actually, let me see if I can get the audio off. I don't know if I can. All right. So I think I'm going to talk about this just off the top of my head without going to the slides, because I didn't realize there was an audio on it. So basically, you know, in contact lenses, we have traditional contact lenses, standard contact lenses, we have custom contact lenses, and of course, we have our rigid and sclerals. So when we're talking about custom lenses to address high order aberrations, their goal is to reduce those high order aberrations. The problem or the challenge is, of course, positional stability, optical surface consistency, and balance of the high order aberration corrections. What I mean by that is sometimes HOAs are not all that bad. Again, when visual function is pretty good with offsets, you got to be careful about that. Now, many of us have used custom soft lenses, and some of these have actually been designed to specifically address high order aberrations. I've been involved in about 3 clinical trials for them with very limited success. I think the biggest problem is getting a consistent surface, consistent rotational stability and such. Of course, custom scleral lenses have the advantage of positional stability and rigid optics, and we can place on these lenses the high order aberration correction optics because of their stability. In the slides before, I'll just jump back to them without showing them. I was talking about how other elements can address high order aberrations. There are some spectacle designs that try to address spherical aberrations, minimal effect. Of course, surgery, we know that corneal shaping anomaly correction, whether it's, therapeutic PRK, a PTK, things like that, we can do topography guided ablations, and John could allude to that a little bit in a few moments, all addressing some of these aberrations that are induced by the shape of the cornea. And then we can consider that also in IOL calculations. What type of IOL? Maybe we want to use an aspheric lens if we have certain forms of spherical aberration in terms of their values and such. Contact lenses, standard contact lenses, often will actually induce high order aberrations, especially spherical aberration. So some of the manufacturers have tried to kind of offset that according to the power of the lens, because we know the influence of the power of the lens can influence high order aberrations. So some of their traditional designs, they're not customized or unique to the individual, but they're just trying to reduce the degrees of spherical aberrations as the power of those lenses are changed and increased. So we're going to now get into the new technologies and the novel contact lens designs that we're using. We've now been working over the last year with scleral lenses that have been designed to address residual high order aberrations. We've been using mostly the Ovid system. We've done a couple of clinical trials on some other designs with a little less success, but this is just the first. There's going to be a lot of work in this area, a lot of interest in this area. So we know that with this system, we can measure aberrometry using their system, overall aberrometry. We can then do it over a traditional contact lens or a traditional scleral lens and see what is residually left over in high order aberrations. And if it's significant, then we can go forward and utilize their proprietary designs to try to address these residual high order aberrations. And there we can see an example. Again, my apologies because there's audio on this. We can see that there's significant high order aberrations residually in this case when we put a contact lens, a scleral lens on this particular patient's eye. Now, we go back and we take a measurement of a traditional scleral doing aberrometry, and we can see there's a significant amount of residual high order aberrations in this particular case. And here we have now designed the contact lens to place optics on the front of this lens that offset the high order aberrations. And the total RMS value was dramatically reduced by about 50%, and function was reported and acuity reported better than with traditional scleral. So now I'm going to let our good friend John take over and share with you tremendously interesting information pertaining to the use of these lenses. John?
Perfect. Awesome. Thanks, Barry. That was a really great, overview of how aberrometry really works and how that application can be done in clinical practice. I'm going to try and just hammer home a couple quick points here as we go through it, and kind of take care of some common misconceptions that are out there. One of the things that we want to look at is topography. Many individuals will see topography and say, oh, topography can give me Zernike polynomials, excuse me, or higher order aberrations. Well, what topography is really doing is it's measuring the corneal shape, right? And it's doing that by looking at the displacement of the rings that are projected onto a cornea and looking at those calculations of the spacing between those rings to be able to determine the corneal shape. So the more ring distortion, the more irregular the cornea is. What's happening, you can convert these various different shapes into various different measurements. You can measure them in dioptric power, you can measure them by elevation, you can also turn those into Zernike polynomials. So you can describe the irregularity of a front surface of a cornea by calculating out the Zernike polynomials and telling us what sort of root mean squares there and what sort of aberrations are created by that surface. But what you're doing is you're measuring the structure of the eye. You're not actually measuring the aberrations of the total eye. You're just converting the shape into those calculations. So when you get those measurements off of a topography, those are not total real aberrations. Those are calculated based on the surface. So we can model this a couple different ways, which is we can go ahead and show it in a map formation like we're used to, or in various different methods that we're used to seeing in topography. If we put a contact lens on that eye, just like Barry was showing, if we put that contact lens on there, we end up changing the anterior surface, and thus we're measuring the contact lens, and that's why we reduce the aberrations up front. So when we go ahead and we go to our next portion here, which is how we're looking at aberrometry, this is truly mapping vision. So what we're doing is we're projecting light into the eye. We're looking at the way that wavefront is projected back out of the eye and then captured on a CCD image. So what we're getting are these little points that are projected onto the grid, and we're looking at the displacement of those dots and the focus of those dots. So on the left, you can see a normal cornea here. On the right, you can see a keratoconic cornea, and the more displacement and the more changes in sharpness of those focal points indicates more aberration. So if we take a look at this, we can represent it in all the ways that Barry had showed before, and we can graph those out in many different ways. Now, obviously, like what Barry was saying, was that's a measurement of the entire eye. So that is full eye ocular aberrations. So can wavefront really be derived from topography? No, they're two different devices. Topography measures just the surface and uses essentially ray tracing to calculate what the optical quality would be, versus aberrometry, which measures total eye aberrations. So kind of think of it like that. So real total aberrations versus inferred aberrations. Now, if we get into it, Barry was talking about a device that can measure tomography with an aberrometer and a biometer in it. If we take a look at the whole eye and we treat it as kind of an optical system where you have a front of a cornea, back of a cornea, front of a lens, back of a lens, and the length of the eye, we can, by these systems, go ahead and ray trace out, or rather calculate out, the aberrations that each individual surface would contribute to the total aberrations, and we could pinpoint those individual aberrations. Now, what they've done is with this system over in Europe, and they're starting clinical trials in the US, is they use this ray trace guided system to be able to create custom ablations for individuals undergoing LASIK procedures. And eventually we'll apply this to aberrated corneas and be able to do some pretty cool corrections for those as well. But the reason why this is so cool, instead of just wavefront guided systems, is that this is going to be able to take into account the compensation factors that Barry was talking about, where the lens may compensate a little bit for the cornea. Well, if we were doing just topography guided ablations for an individual, we weren't able to calculate for that. If we were doing wavefront guided ablations, we were only able to calculate that for a certain extent. So when we look at this, this is going to take into account all of that information and be able to give us way better refractive outcomes. Now, when we go to one of the questions that was in the Q&A was, are the numbers comparable across different machines, and are there any, kind of common cutoffs or RMS values that should make you pay more attention, right? Well, aberrations are variable based on pupil size, right? And whether we're outside, in the bright, or we're out, nighttime in the dark, where our pupil is changing sizes, that's going to change the amount of light that comes into the eye, and thus the amount of aberrations that's present. So if I sit in front of an aberrometer, and let's say I'm looking, at that aberrometer and the target in there, I may be able to get, one measurement, but let's say I start to accommodate to the target inside of the device, and, because of, accommodative constriction, I'm going to get a smaller pupil, and now my aberration measurement is going to go down. So even just within from, measurement to measurement, we're going to get differences in that. But then there's also an age-dependent component on this. This is Marsak's work, or rather, Ray Applegate, Marsak, all those great scientists at University of Houston. This is their work, and they show that there is not just pupil dependence, but also age dependence on this. So as you get older, you're going to have more aberrations. As you have larger pupils, you're going to have more aberrations. And then just like any other device, let's say I'm measuring my my aberrations on, I don't know, an Ovitz device, and Barry's measuring his on an OPD3, and you're measuring yours on a iTrace, and another person is measuring theirs on, whatever sort of systems there are. Those are not going to be apples to apples measurements either. So when we look at this, obviously if I take, several measurements on the same device, we should have general agreement within those. But, these are all the factors that we got to think about for these individuals. Now, when we look at, wavefront guided scleral lenses, like Barry was saying, these have, there's been a lot of different trials that have gone on for these. Wavefront guided scleral lenses this is not a new concept. The first patent on this was the Magnanti patent, and that was filed in 2002. So it has been around for a very, very long time. The first publications on this really started coming out in 2013. I believe in 2011 maybe was one of the first ones in contact lenses. But when we look at this, this is Marsak's group. This is Genyoung Yoon's group. And Lynette Johns holds a patent in this with Genyoung, and Roxana, who's on right now, Dr. Mahdi has also contributed to this work as well. So when we look at all these papers, what we're finding is, in general, there's kind of a reduction of higher order aberrations from 43 to 66% in those areas, 1 to 2 lines of visual acuity improvement. This has been pretty well established, but the problem is that it's a simple concept, but it's difficult to execute in clinical practice because there's just a lack of logistics with this. With our goal, what are we doing here? Well, we're creating essentially disruptive interference when we're using these higher order aberrations. So what are we doing? Well, we're mapping the aberrations, and just like this is easier to understand in the set of noise canceling headphones, right? We have a sine wave or sound wave coming in. The headset creates a equal and opposite sound wave, and because of the disruptive interference, we get noise cancellation. So the same thing is happening with the higher order aberration correcting contact lenses. Our goal is to measure those aberrations of the total system with the contact lens in place, take those aberrations, and then go ahead and manufacture those and put those into the contact lens. So we can end up with, let's see here, trying to get those up. This is from, again, Marsak's work. What you can see is the measured aberrations there, the total. Then what they do is they're going to go ahead and manufacture or flip those into the, in what's going to be manufactured into the front surface of those lenses. And then when you take the aberrations over the new higher order aberration correcting lens, you can see that the wavefront significantly improves, and thus the vision is corrected. So why are we picking a scleral lens? Well, it's because of stability. Now, we tried to do this early on. We did multiple clinical attempts without a system in place. We followed the research outlined in this with no integrated system or aberrometry in place, and it was fraught with issues. We had to do a whole bunch of, essentially non-standardized work here, measuring out, different measurements of decentration, using several different aberrometers, trying to jailbreak the information out of the aberrometers, and then send it into the lab. These were the same eyes. We got totally different results out of it. Did it work? Kinda, not really. We had 1 out of 7 patients that we tried this on was successful. In the integrated systems that are now available, what we're getting is, the full ability to measure this with a lens and directly transfer the information out, and the system just measures the decentration of the rotation of the lens, and you get complete data. The optics are fully customized to the individual, and this is submitted directly to the lab. I get a lens back, and that's kind of it. So Down at the bottom, you can see the difference between the over topographies on these lenses. You can see the spherical lens on the left, or the lower order aberration correcting lens on the left, and the higher order aberration correcting lens on the right. And you can see the differences in the topography of those lenses. This is physically ground into the front surface of the lens. Another misconception that we have on lenses is eccentricity on contact lenses. Barry touched on this, but many lenses out there, we can use eccentricity to control some of the aberrations, but these are not customized to the individual, right? What we're doing is we're essentially changing the levels of spherical aberration that are present. In this individual, this is an individual wearing a scleral lens, and what we did was we used a lower eccentricity, a mid-level eccentricity, and a high-level eccentricity for the lens front surface, and you can see how we greatly changed the aberrations present. When we look at this, essentially what we're seeing is that, yes, we can change it, but we can't eliminate it, right? We can't fully customize this for the individual. We can improve, though. So what we're doing here, this was a case study. Actually, this was recently. We just actually today got the information that this was available before print. But this was a patient of ours, just like Barry had talked about with the patient where you put the scleral lens on and their visual acuity is not any better. This was our patient. This is a cardiothoracic surgery fellow, comes in, uncorrected visual acuity, 20/30 minus in both eyes. He's having a hard time. He's going, I need it to get better. I put scleral lenses on him. I go, this is going to be great for you. 20/30 with those, and I can't get him any better. What we do is then we go ahead, we convert to an ocular impression based scleral lens with the Wavefront guided optics on it. And we got a 67 and a 64% reduction of his aberrations and brought him from 20/30 to 20/20, happy as can be. So another one that we did, we looked at some retrospective data. This was presented at the beginning of 2021 from some retrospective work that we're doing in our clinic with that Ovid system. And what we were looking at was 31 eyes, and we looked at their best corrected visual acuities on this group. We could see that they improved about 1.5 lines, and their higher order aberrations reduced by about 55% compared to the traditional optics on a lens. If we look at their best corrected visual acuity of this cohort, 94% of the individuals improved 1 line or more. If we looked at those individual eyes, only 6% or 2 eyes showed no change in visual acuity. But the thing that's very interesting about this is if we go to the aberrations and we look at all those eyes, all eyes had a reduction of aberration of 30% or greater. And everybody that we've tested so far in this subjectively appreciated the change in those aberrations. So this was pretty impactful. The next thing that we did was we looked at eyes that had intacts. Again, this was presented in the early data. At this point, we have about 200 eyes that we're looking at and we're doing the retrospective on right now. But when we look at this, this was just 6 eyes of 4 patients with intacts in it, right? We know, the problems that happen with intacts. So what we found in this group, 1 line of visual acuity improvement and 54% reduction of aberrations. So pretty comparable to what we were getting otherwise. The other thing that we want to note is that some neural adaptation does happen in these individuals. You want to give these individuals a bit of time to adapt to wearing their lenses and adjusting to the new visual, the visual presentation that they're going to have. So what we did was we looked at 11 eyes of 8 patients. We did a crossover in these, which was we measured their visual acuity and their aberrations at dispense. We followed up in 4 weeks. And we looked at the differences in there. So at dispense, 3 of the 11 eyes showed no improvement in visual acuity. But at 4 weeks, all 3 of those eyes showed an additional line of visual acuity improvement. So what we're looking at in this and what you're seeing in the comparison there, the reason that you're not seeing a statistically significant difference between the higher order aberrations between the baseline and the dispense and the final is because the aberrations are not changing. It's just that their brain is starting to use this information better, so they're gaining that additional line. So, before you go, oh, well, I put this lens on them, they didn't really get any better, definitely take that into account. They need some time to adapt to this. Now, we're also experimenting with the ability, first we're trying to knock out the aberrations, right, to make the vision better for these. But what if we can knock out those aberrations and then add in just a little bit of desired aberration? Like in this case, we're trying to add in just the right amount of spherical aberration. So this is a wavefront guided EDOF optic on this. So what we did for this individual was we corrected all their aberrations with their wavefront guided scleral, and you can see that their aberrations really decreased compared to their traditional lens. But then we added in a little bit of that spherical aberration, just the right amount to give them a little bit more near and some more depth of focus. And you can see that those aberrations that we added back in are still less than what they had in the traditional scleral lens optics. And you can see that this individual went significantly or ended up being significantly improved. Now, there's a lot of questions, a few things that have been answered so far. This is mostly Marsak's group. They're definitely the leaders in this area. One of the questions that was asked is, does misalignment matter? Yes, it has a significant impact on visual acuity. Does wear and tear matter, cleaning these lenses over time? Well, they found that cleaning these lenses over a 12-month period of time did not clinically significantly clinically significant change to the performance of this. Do coatings matter, adding like HydroPeg or other sorts of things like that? No, those were clinically insignificant. Does stability matter? Yes, absolutely. Toric haptics were needed for the stability of these lenses. And as we start moving into more freeform designs, those may give us an even higher level. Now, some outstanding questions are, where do we stand on dilating patients? What topical agent works the best? When we put a lens on an eye, how long does it take for that lens to settle into position so that we know that we're getting the right position to take those aberrations over the top? What's the impact of things like fogging under the lens or deposits on a lens surface? So a few things that are outstanding and need to be answered. And I'm sure lots of research will be done in this area. Another challenge on this is, why aren't we getting perfect optics? Well, it's a dynamic visual system, right? We have the tear film, we have the lens, we have the pupil. All of these are changing when we're doing these sorts of things. So yes, sure, we can get a great measurement in, a period of time, but we may not get, that variability that's there. The other question is, does everybody do well? Well, if we have media opacities, we may get some scatter. And if we get, a decentered optic on there, we may get bisecting of that visual axis, and that will cause some issues. So with that, Barry, you want to hop on? We'll answer some Q&A, and we'll go from there.
It sounds great. Great job. Great information. I hope everybody appreciated what John had to share. It was spot on. I've just started looking actually at some of the questions, and they're really, really good questions. Here's a great one. Our good friend Tiffany from Chicago asked, when it comes to HOAs, how can you tell if the residual HOA is due to posterior cornea versus the lens, especially if you're trying to decide if you should refer a keratoconic patient who wears contact lenses for cataract surgery? John, you want to jump on that one?
Ooh, yeah, that's a tough one. It really depends on the technology that you have, right? Because if you only have the ability to map out a front surface, so like if you're using a topographer that's integrated with an aberrometer, the challenge there is always going to be that you're only measuring the front surface of the cornea, right? So if you're looking at the internal aberrations, some of those internal aberrations are coming from the posterior cornea. Really, the only way to really do this is on some of the tomography devices, where it'll actually divide out the surfaces for you. It'll tell you, here's the front surface aberration, but here's the posterior corneal surface aberration as well. And based on that, if you had, let's say, if you had a non-integrated system, let's say you had an individual tomographer, and then you had a standalone aberrometer, you could look at those and say, okay, here is the contribution from each one of those surfaces. say, okay, here's the contribution from the total eye, and you could kind of estimate that on your own, but that's going to be a tough thing because the calculations in this are very, very sophisticated. I mean, Marsek knows, Roxanne, you might know, but I don't know that.
Yeah, that's definitely a Jason thing. I don't even deal with that.
Well, you know, I'll add a little something to what you said, John and Tiff. Basically, you know, I think one of the keys is if you have information from prior and you know, let's say you've run a penacam on patient and their penacams have been absolutely stable and their height or aberrations are increasing, you know, and you're seeing the cataract form, I think just by simple deduction, that's the best way. Of course, the new AXL wave system it really has the ability to do that and differentiate out the back of the cornea, front of the cornea versus the lens. So that's, I think, going to be very, very helpful. I'm going to pick and choose if that's okay, Roxana.
Sure. Yeah. Okay? If you want to, you can. Yeah. I'll just.
Because our buddy Ray Brill. Hi, Ray. He said he loved his ophthalmics. He's showing his age. Adverometer to design eyes-on spectacle lenses years ago. Do any of these aberrometers translate similarly to making spectacle lenses? John, tell Ray, and I'm sure Ray knows this anyway, but all of our attendees, what is the challenge to address HOAs with glasses?
Yeah, optical center. You know, what happens is when you have the contact lens on, it moves with the eye, just like everything else that's beneficial of those. But if we're going to cut a perfect aberration correction, like, and when you look at Marsek's paper on, you know, Hastings paper, yeah, but Marsek's group anyway, when you're looking at the rotation decentration of lenses, a very, very small amount of rotation or decentration makes a huge difference. If you look at lenses they put lenses on eyes that were created directly to the line of sight, and then some that were geometrically centered. And what you saw was this massive disruption of vision, change in the aberration. So if you're doing that in a spectacle and you're not looking perfectly into the optical center of those, right into the line of sight, they're going to end up with way worse vision than what they would have had with the positive outcome on that. Now, it's super funny that you bring up the orthodontics. I was actually literally the other day, you know, I do a little bit of work with a few things on this. So I was looking up old, you know, articles and patents on it. I was looking at Jerry Ledgerton's 2004 Review of Cornea Contact Lens article on the emergence of wavefront guided optics in contact lenses. Right. And there's actually a picture of the orthodontics, the Z view in the article. So
as typical, Jerry is usually at the forefront, way ahead of us. We just never understand him when he presents it. We said, "What is he saying?" And then we realized, like years later, that's what he was saying.
Yeah, he was right, man. I mean, he had that before the patent got issued. It was crazy.
Those of you who don't know Jerry Ledgerton, probably one of the most brilliant minds in our field, has come up with so many things that we use on a day-to-day basis. Alan Wee asked, how significant is the posterior cornea? I've heard from several anterior topography people who tend to dismiss it. Maybe because they can't see it. Well, maybe because they can't sell it is what my answer would be. Of course, they'd want to dismiss it. It is significant. It is obviously not anywhere as significant as the optical influence of the front of the cornea, but we see it every day in clinical practice. Again, what you don't look for, you can't measure, you can't see, you don't know. And Alan also, one second, had another great comment.
He was the top one at the very top there.
The top one up there. Yeah. No, I think the comment was when he said this was a spectacular presentation. That's what I wanted.
No. Yeah, I think.
Anyway, yeah.
So there is one question on here that maybe I'll kind of help with. So this is Alan again, which it was, you know, are there cutoff values or certain RMS that should make you sit up and pay more attention? The main one is if you look at the individual polynomials, right? So if we're looking at the higher order aberrations, we want to specifically look at coma and trefoil as being the two that are elevated and should cause concern. If we look at like some of the seminal work from, Lim and Kosaki, these papers from back in, I think, 2007, maybe even a little earlier than that. But what they found was that coma, specifically vertical coma, is very highly statistically significantly correlated with keratoconus. Obviously, in advanced keratoconus, but even a differentiating factor in those with early keratoconus. So pay attention to coma, pay attention to trefoil. Those were the two highest ones. Obviously, total aberration can be a big one. A general sort of rule of thumb on that one that I've used has just been kind of, if they're around 6 and they're kind of around 0.3 on total, that's where, you should be kind of going, all right, that's kind of normal. But, when in doubt, get a topography so you can look at the cornea and see what's going on there, and then, do some investigation.
So there was a really interesting question, Alexander. Without aberrometry in the office, is there any way that a scleral lens practitioner can utilize this information to help offset, or he said, fought or fight HOAs with traditional scleral lenses? My take is, without having an aberrometer, if you put a scleral lens on, and obviously we don't get the kind of improvement in acuity and the quality of vision, even as the patient says to you, those patients who start reading the eye chart like A, P, P, S. So, what I'm saying? That they're not seeing it well, even though they may have a quantified acuity. You have to be suspicious after a well-performed over-refraction that there's residual HOAs there. There is really no way other than in traditional sclerals, you're offsetting the anterior corneal hilar aberrations from distortion, but lenticular and posterior corneal, you're not. Just what it is. Yep.
Yeah, I think the only way that I could think of to address that would be, there is, wait, we're not under COPE violation now because we're in Q&A, right?
I think we're past the COPE portion of it, but yes, let's try to still be a little bit.
I'll keep it vague.
Yeah,
So, there is a set that exists out there that has 3 different versions of front surface eccentricity in the set, and subjectively you can take a lens off, put it onto the eye, have them look through the over refraction and say, how does that look subjectively? You can take that lens off, put another lens on with a different eccentricity, and ask them like that. That's kind of a standardized way that you can do this. But it is, there is some, misconception there, which is, those are not customized for the individual. What we're talking about tonight is customizing it like it's your own fingerprint. This is aberrations for that individual.
Right. It's that next level. Tom W. had a great question. And he's worked with the Ovitz design using a specific type of scleral with mixed results due to decentration, rotation. And he was wondering if CSP-based or impression-based technologies would be something that would result in better outcomes. John is going to respond to this very clearly, but I agree. The better you can get the stability and centration of these fits before you apply that HOA correction on the anterior surface, the better your outcomes are going to be. And sometimes because of the position of the visual axis, even the ability to offset the optics appropriately, and again, a customized way, is going to help. Because if you have an offset optics, you're going to even induce certain high order aberrations that may not be part of the patient's visual system, but now part of the lens patient visual system. Would you like to comment, John?
Yeah. So, sorry, I'm just trying to, Rox, can you give me the question again?
He was just asking, Tom was just asking if the use of, more of the unique designing capabilities, CSP designed, for impression.
Yeah. Okay. So right now we've done a lot of work in, posterior, impression-based, scan-based, and diagnostic-based wavefront guided lenses. We have not done a comparison between them, so I could not tell you confidently that one is producing better outcomes than the other. I can tell you that, if you break this down into its most simplistic format, which is how do you operationally do a wavefront guided lens? The first thing that you have to do is make sure that you have a perfect stable fit. Once you have that, you need to look at where your optic zone is in relationship to your perfect stable fit. If your optic zone is bisecting the pupil, they can't do anything about that, unless they can enlarge your optic zone to, take care of it. That's move to something else that'll center better. In the case of individuals who, that is what I run into, and this is just in general, scleral lens fitting, is that if you don't have a stable platform, you're not going to get stable optics, and that's extraordinarily important in wavefront guided lens fitting. So something that I may have accepted is saying, hey, that was good enough. They're doing great. It's, the lens looks good on the eye. It's not causing any issues. Sure, it's got a little tiny bit of movement or rotation, but I don't care about that. That's fine. They're out the door. In this, it matters. You cannot accept any sort of movement or rotation of the lens. And that can make this a little bit challenging, but, those other systems, they can certainly help solve some of that. But yeah, no, really just, you got to take your level of acceptance and bring it up a notch, and then you go pretty well from there.
Just a reminder for everyone, this webinar will be available online to review later, should be later this week. And then please join us next month for our webinar. I believe that's on the next slide there. Yes, for our webinar on practical approaches to improve clinical efficiency and patient outcomes with Dr. Karen Delos and Dr. Jamie Kuzniar. So we look forward to seeing y'all on Wednesday, September 7th. Thank you, John and Barry, for this awesome webinar. It was great. We learned a bunch. And we look forward to having y'all next time.
Bye. Cheers.